Hi everyone, welcome to today's webinar, The Intersection Between Meaningful Work and Compliance, Social Determinants of Health and Quality Reporting. My name is Radhika Sabnis. I am a program coordinator with Health-Centered Advisors and I work on the Quality Payment Program for eligible clinicians. And I'm joined today by my colleague, Kelsey Baker, who is also a program coordinator with Health-Centered Advisors and works on the Quality Payment Program for eligible clinicians. Next slide, please. This is just a disclaimer that these slides were prepared with help of CMS material by Health-Centered Advisors, and we apologize in advance if there are any errors in this presentation. Next slide, please. So here are the objectives for today's webinar. Firstly, we will explore a little bit about social determinants of health and also why this is such an important topic. Then we will talk about various quality reporting programs like MACRA, QPP, Medicaid reporting, and as well as patient-centered medical home or PCMH reporting. And we will also go over a few relevant quality measures and activities and ICD10 codes. Next slide, please. So what are social determinants of health? According to CDC, these are the conditions where people live, learn, work, and play, and affect a wide range of health risks and outcomes. So how do these conditions affect our health outcomes? We know that poverty affects the access to stable housing, safe neighborhoods. It also limits access to healthy food, education, and also to good jobs, which leads to low income. Now, these factors can be a cause of stress and also affect health outcomes, which lead to poor health compared to the population who aren't affected by these factors. So basically, poor social determinants of health lead to health inequities. So what are health inequities? They are health disparities between different population groups based on distribution of health determinants arising from social conditions in which those people are born, grow, live, and age. Slide, please. Now coming to the term inequities or equity. So the word equity can be confusing. I know I was when I first heard of this concept. So here is a picture that explains the difference between equity and equality. Basically, this picture shows each person is different and therefore has different needs. So to achieve equity, one needs to tailor the resources you provide to people according to their needs, just like in the second half of this picture. Slide. The graphic is taken from Healthy People 2020 website, which is a national health improvement objective led by the Office of Disease Prevention and Health Promotion, ODPHP. Almost all underlying social determinants of health factors can be grouped under these 5 key areas. Beginning with economic stability, there are factors like employment, and that is not just any form of employment, but a good job, food insecurity, housing instability, and poverty. All these can be grouped under economic stability. Then there is neighborhood and built environment, which comprises of factors like quality of housing, access to healthy food, crime, and in general, environmental conditions. Then we can group in general maybe access to healthcare or even having basic health literacy under health and healthcare. Then there is social and community context. We know that social isolation has a deep impact on health. Having some sort of social cohesion and not being subject to any form of discrimination is very important for health of any individual. And lastly, there is education as a social determinant of health. Early childhood development and education can have a deep impact on the life and health of an individual. Just having access to these and higher education plays an important role in the life of an individual. So why are social determinants of health important? As we discussed earlier, poor social determinants of health lead to health inequities, which in turn lead to significant financial costs to societies. Per the WHO website, the European Parliament has estimated that losses linked to health inequities cost around 1.4% of gross domestic product, GDP, within the European Union, a figure almost as high as EU's defense spending, that is 1.6% of GDP. So basically, these losses arises from losses in productivity, tax payments, higher welfare payments, and something very important to us, that is high healthcare costs. So how do social determinants of health affect providers? We know that health equity is an important goal for CMS, that is Center for Medicare and Medicaid Services. They have been increasing efforts from CMS's end to understand and increase awareness of disparities among various populations and various regions. Also, CMS has been encouraging innovative and creative solutions to address the needs of disparate population and accelerating implementation of effective solutions. This is evident from the measures that are related to social determinants of health that are listed in the newer payment model. We will be talking about these measures later in this presentation. We will also be going over the ICD10 Codes for patient non-compliance. Hopefully, these will help providers to continue to deliver high quality of care to complex, high-risk patients without being in the fear of being penalized, and focus on patient population which has unique vast amount of work has been done in the social determinants of health or health equity realm, and many organizations continue to collect data on health disparities and are trying to come up with innovative solutions. Today we are going to mention some distinguished work and research that has been done around today's topic of presentation, but this is just the tip of iceberg. Starting with Department of Health and Human Services, HHS work called as National Partnership for Action. The HHS Office of Minority Health Initiative, National Partnership for Action, abbreviated as NPA, is to increase the effectiveness of programs that target the elimination of health disparities through the coordination of partners, leaders, and stakeholders who are committed to action. Now, through the NPA, some health equity councils were formed, namely Federal Interagency Health Equity Team, abbreviated as FIHET, and Regional Health Equity Council. The goal of these teams and councils is to identify and facilitate collaborative, action-oriented approaches to address HHS minority health, racial and ethnic health disparities, and also to effectively and efficiently share information within HHS. And to address social determinants of health, we firstly need good data resources. So, Federal Interagency Health Equity Team recently published data compendium of all data resources available for addressing social determinants of health. The purpose of FIHET is to identify opportunities for collaboration, partnership, and action. And the purpose of NPA is to provide leadership and guidance for federal, regional, state, tribal, territorial, and local efforts to address social determinants of health. And most important, infuse health disparities and health equity goals and strategies into member agency policies and practices, which is key in bringing about a change in social determinants of health conditions. This is another notable project in social determinants of health realm from National Quality Forum, NQF, which is a non-profit healthcare improvement organization working with quality measurement and public reporting space. Now, if you're familiar with the quality payment program, you would know that NQF is a measure steward for many of the quality measures in the program. Now, this project is called a roadmap for promoting health equity and eliminating disparity. 4 I's of health equity. To quickly summarize this project, the National Quality Forum, with funding from Department of Health and Human Services, convened a multi-stakeholder committee comprising of experts in disparities, social risk factors, and healthcare quality improvement, clinical and measurement expertise to develop a roadmap that demonstrates how performance measurement and its associated policy levers can be used to eliminate disparities. The roadmap provides guidance for addressing a wide spectrum of disparities based on age, gender, income, race, ethnicity, nativity, language, sexual orientation, gender identity, disability, geographic location, and many other social risk factors. This roadmap includes measurement beyond clinical settings, structures, and processes of care. For example, it includes the assessment of collaboration between healthcare and other sectors to reduce the impact of social risk factors. Examples: schools, social services, transportation, housing, etc. The roadmap lays out 4 actions, 4 I's for health equity that healthcare stakeholders can employ to reduce disparity. First I is identify. Identify and prioritize reducing disparities. Second is implement. Implement evidence-based interventions to reduce disparities. Third one is invest. Invest in the development and use of health equity performance measures. And last I is incentivize. Incentivize the reduction of health disparities and achievement of health equity. And the 4th I is particularly interesting because it talks about utilizing the growing adoption of global payment systems like APMs, alternative payment models, and accountable care organizations, ACOs, and value-based purchasing programs in the U.S. healthcare system to better address disparities and incentivize the achievement of equity. And now we will talk about one last piece of work in this realm. It is the 2017 National Healthcare Quality and Disparities Report by Agency for Healthcare Research and Quality, EHR, pronounced as ARC. Now, this is one of the 12 agencies within HH. This agency primarily works on projects that produce evidence which eventually help make healthcare safer, implement higher quality of care, make healthcare more accessible, equitable, and affordable. This report is based on more than 250 measures of quality and disparities covering a broad array of healthcare services and settings. This report assesses the performance of a healthcare system and identifies areas of strengths, weaknesses, as well as disparities and access to healthcare and quality of healthcare. We know clinicians have to undergo the monumental task of reporting to the program, but some of these measures that clinicians report to can help us identify areas of weakness, disparities, and areas that need improvement. Now, linked to all of these articles and projects are in the resources slides towards the end of slide deck. Moving on to the next section of this presentation, reporting program.
Hi, I'm so sorry. I just wanted to jump in. It sounds like we're hearing a little bit of background noise, so folks could just check if they're on mute, and if not, just hit your manual mute button on your phone. Thank you so much.
Thank you. As mentioned earlier, we will be specifically talking about 3 quality reporting programs. The first one is Medicare Quality Payment Program, and then the Patient-Centered Medical Home Recognition Program by National Committee for Quality Assurance, and lastly, Medicaid quality reporting. Now, all these quality reporting programs ultimately have the same underlying goal of improving quality of care, improving access to care, improve healthcare in general, and decrease cost optimization. I'm sorry, I can still hear some background noise. Could you please mute your phone? Thank you. Now, this slide is just to give you a visual idea. In this section of presentation, we will basically be focusing on the area where these key reporting programs address social determinants of health. All these reporting programs have similar quality measures, if not identical. My colleague Kelsey will be covering these measures in detail later in this presentation. Starting with the Quality Payment Program, abbreviated as QPP, comes from MACRA legislation, that is Medicare Access and Reauthorization Act. And this is a bipartisan legislation that repeals the flawed SGR, Sustainable Growth Rate, in an effort to reduce Medicare spending. And from the Quality Payment Program, we have two types: MIPS, that is Merit-Based Incentive Payment System, and APM, Alternative Payment Model. Reporting via MIPS include MIPS-eligible clinicians who are not part of an accountable care organization or larger health system. These clinicians can report individually or as a group on quality improvement activities, promoting interoperability and cost category, and get scored based on their performance. They receive a positive payment adjustment based on their performance anywhere up to 7% for the performance year 2019. Clinicians reporting via the Advanced APM track may receive 5% lump sum payment adjustment as they accept both risk and reward for providing coordinated, high-quality care simply by being part of an APM. Advanced APMs typically have greater revenue risk and opportunity. And so for purpose of this presentation, we will keep the focus on MIPS track. So who is eligible for MIPS? Physicians, including doctors of medicine, doctors of osteopathy, osteopathic practitioners, doctors of dental surgery, doctors of dental medicine, doctors of thoracic medicine, doctors of optometry, chiropractors, clinical nurse specialists, physician assistants, nurse practitioners, certified registered nurse anesthetists. And now in the performance year 2019, there are additional eligible clinician types, like physical therapists, occupational therapists, clinical psychologists, qualified speech-language pathologists, qualified audiologists, registered dietitians, and nutrition professionals. And so simply being an eligible clinician type is not enough. These clinicians need to meet what's called the low-volume special criteria, which is submit more than $90,000 in Medicare Part B claims annually, care for more than 200 Medicare patients annually and are excluded from MIPS, and provide more than 200 covered professional services under physician fee schedule. And 2019 should not be your first year submitting Medicare, and you should not be a participant of an advanced APM or what is called as QP, qualifying APM participant, and also not be part of Medicare Advantage qualifying payment arrangement incentive participant. I won't be going into too many details of the performance categories, but there are 4 performance categories from it. The first one is quality performance category, which has the highest weightage among the 4 categories, which accounts for 45% of the total net score. The next one is promoting interoperability performance category, which is 25% of total net score. Then there is cost performance category, which constitutes 15% of total net score, and improvement activities performance category also constitutes 15% net score. Based on performance in these 4 categories, physician may get a positive payment adjustment in the payment year 2021, or get a negative adjustment if they score below the performance threshold, which is set to 30 MIPS points. And like I mentioned earlier, MIPS payment adjustment is made 2 years after the performance. For example, for performance year 2019, payment adjustment will be made in 2021. And the payment adjustment for performance year 2019 is plus or minus 7% based on clinicians' performance in the 4 performance categories. And with that, I will hand it over to Kelsey. Kelsey, take it away.
Thank you. All right, so before we dive in, I just wanted to make a note. So we have listed some quality measures and improvement activities that can be reported on through QPP that address social determinants of health, but I want to say that in no way is this an exhaustive list. Something like 257 quality measures and 118 improvement activities. So again, this is certainly not an exhaustive list, but rather a good starting point. So starting to look at these measures, You can see adult major depressive disorder, childhood immunization status, and developmental screening in the first 3 years of life. These are all screening-related measures. The reason that these are so crucial to addressing social determinants of health is that, due to some of these determinants, it might not be feasible for folks to get to their doctors regularly. Thus, that individual might not be asked about behavioral health or asked about their immunizations. So checking off these boxes are really important for addressing social determinants of health. In the bottom right-hand box, you'll see the measure follow-up after hospitalization for mental illness. This is a great one for practices and providers who treat individuals with mental health conditions. As we know, mental health conditions are often unpredictable for the folks who live with them. So if they're decompensating or symptomatic, rather than calling their ongoing PCP, they usually just end up in the emergency room or some other urgent care setting. So it's important to follow up after the patient is hospitalized so that you're able to reconcile their medications, because they've likely changed, and make sure that the patient has community support at home so they can stay safe after they return home. On the measure on the bottom left-hand side, continuity of pharmacotherapy for opioid use disorder, this measure is looking at the percentage of patients with an opioid use disorder who have been in pharmacotherapy treatment for a minimum of 180 days. Ensuring that your patients with any substance use disorder have a variety of treatment options is crucial to providing holistic care and addressing social determinants of health. Okay, so you'll see here there are 3 measures that say preventive care and screening. So there's the screening for depression and follow-up, tobacco use screening and cessation intervention, and unhealthy alcohol use screening and brief counseling. So these are related to some of the screening stuff I was talking about on the previous slide. There's also a measure of tobacco use and health quitting among adolescents that can be reported on as well. There's another measure related to weight assessment and counseling for nutrition and physical activity for children and adolescents. So this addresses some eating habits and access to healthy food for children and their families. And as a provider, you might find out doing this that the family lives in a food desert or maybe doesn't have the financial resources for healthy food options or doesn't have transportation to get to the grocery store that's closest to them. So this measure can help enlighten clinicians about the state of food and security in the family's home. So now that we're going to start talking about some improvement activities, I wanted to point out that for Performance Year 2019, CMS created a new subcategory for improvement activities called Achieving Health Equity, and they all address social determinants of health. So we put them all here. We've also added a few more. So the first one you'll see here is comprehensive eye exams. And you might look at this improvement activity and think to yourself, how does this end up on this list? It doesn't seem super related to social determinants of health, but in fact it is. So this improvement activity specifically must be targeted at underserved and or high-risk populations that would benefit from engagement regarding their eye health with the aim of improving access to comprehensive eye exams. So, for example, someone with poorly controlled diabetes who doesn't really live close to their doctor to receive regular eye care. So right below that, you'll see leveraging a QCDR for use of standard questionnaires. For anyone who is participating in a QCDR or Qualified Clinical Data Registry, this is demonstrating performance of activities for use of standard questionnaires for assessing improvements in health disparities related to functional health status. So, for example, the Seattle Angina Questionnaire or the MD Anderson Symptom Inventory, which are patient-reported outcome tools, which leads me to the next improvement activity, bottom middle, promote use of patient-reported outcome tools. So this could be using the PHQ-2 or 9 to address depression or the wound quality of life patient-reported tool. Using the patient-reported tool demonstrates that your practice takes into consideration the patient voice and allows them to self-report their conditions and their symptoms as well as their personal needs. On here, we've also listed the improvement activities, electronic health record enhancements for behavioral health data capture, as well as depression screening. So socioeconomic inequalities in health have been widening for decades. In the United States, the data consistently show that people living in poverty and particularly those of racial and ethnic minorities, bear a disproportionate burden of exposure to unhealthy environments and are at a much greater risk for mental and behavioral health-related conditions. So it's because of this that it's so critical to screen patients for any behavioral health conditions or symptoms so that they can be addressed early enough and interventions can be put into place for that person. All right, so here's a few more proven activities. So the first one we'll see is diabetes screening. So this improvement activity is actually looking at if you're implementing diabetes screening for people with schizophrenia or bipolar disorder who are using antipsychotic medications. So this is pretty specific to that population and for good reason. Folks with mental and behavioral health conditions often get screened for chronic conditions and get treated for chronic conditions far less frequently than for those without mental and behavioral health conditions. So then to the right, you'll see engagement of new Medicaid patients and follow-up. So we know that in general, individuals who are insured via Medicaid or who are dually eligible, Medicare and Medicaid, often live in poverty and have decreased access to care. So attesting to this activity can help ensure that those individuals are getting the quality care that they need. Then on the bottom left, leveraging a QCDR to standardize processes for screening. So this one's pretty self-explanatory, working with your QCDR to standardize processes for screening for social determinants of health, like food security, employment, housing. Then in the bottom middle, we have NIPS-eligible clinician leadership in clinical trials, or CDTR. So this improvement activity assesses NIPS-eligible clinician leadership in clinical trials, research alliances, for community-based participatory research, that's the CDTR, that identify tools, research, or processes that can focus on minimizing disparities in healthcare access, care quality, affordability, or outcomes. And lastly, provide education opportunities for new clinicians. So this measure is actually looking at NIPS-eligible clinicians who are acting as a preceptor for clinicians in training, such as medical residents or fellows or medical students, physicians assistants, nurse practitioners, or clinical nurse specialists, and accepting those clinicians for rotations in community practices in small, underserved, or rural areas. So now that we've covered a bit about the quality payment program, we'll move on to another reporting program, which is Patient-Centered Medical Home, or PCMH. So before I begin, I just want to note that myself and a few of my colleagues here at Health-Centric Advisors are PCMH certified content experts, and we're happy to help you or your organization obtain or maintain PCMH recognition at no cost. So if that's something you're interested in, just reach out to me after the webinar. I'd be happy to help. So for those of you that might not be super familiar with PCMH, it's essentially a model of care that puts the patients at the forefront of care. They build better relationships between patients and their clinical care teams, and research shows that PCMHs improve quality and patient experience, as well as increase staff satisfaction, all while reducing healthcare costs. Under the PCMH model, there are 6 concepts, which include many criteria or measures that need to be reported on. Some are core or required, and others are either 1 credit or 2 credit, and these are elective criteria. You must report on all 40 core criteria and 25 elective credits in at least 5 of the 6 concepts. So the concepts that we have are team-based care and practice organization, knowing and managing your patients, patient-centered access and continuity, care management and support, care coordination and care transition, and performance measurement and quality improvement. Social determinants of health are really sprinkled throughout all the concepts, but particularly in one of them. So in the concept knowing and managing your patients, or KM, it looks at practices that capture and analyze information about patients and the community it serves, and uses that information to deliver evidence-based care that supports population needs and provision of culturally and linguistically appropriate services. So the criteria in this whole concept practically address social determinants of health, but there are a few that really hone in on it. So in the criteria KMO2, it's called Comprehensive Health Assessment. So it includes getting a comprehensive health assessment on your patients, which includes a medical history of the patient and family, a mental health and substance abuse history of the patient and family, family, social, and cultural characteristics, communication needs, behaviors affecting health like risky or unhealthy behaviors, social functioning, social determinants of health, developmental screening, and advanced care planning. And under another measure, KM07, that is social determinants of health, understands social determinants of health for patients, monitors at the population level, and implements care interventions based on these data. So after the practice collects information on social determinants of health, it can demonstrate the ability to assess the data and address identified gaps using community partnerships, self-management resources, or other tools to serve the ongoing needs of its population. Routine collection of data on social determinants of health, like in the previous measure that I mentioned, KM02, is an important step. But the real benefit to the population comes when the practice uses the information to continuously enhance care systems and community connections to systematically address needs. Other criteria in this concept are related to social determinants of health, like behavioral health screenings, health assessments, problem lists, patient education levels, substance use, community assessments, and providing community resource lists to your patients. Primary care screening strategies have been developed for specific psychosocial issues like substance abuse, maternal depression, but there's emerging evidence that similar screening for basic unmet material needs like food, employment, benefits, education, etc., at primary care visits can increase physician referrals and family contact with community resources. So the PCMH model offers new opportunities for monitoring the basic unmet needs of vulnerable adults, particularly the elderly, and linking them to community resources. In 2017, PCMH revamped their program a bit and added 3 distinctions practices can achieve. So behavioral health integration, patient experience reporting, and electronic quality measure or ECQM reporting. And we are going to talk about the behavioral health integration distinction. Several factors have been linked to mental health, including race and ethnicity, gender, age, income level, education level, sexual orientation, and geographic location. Other social conditions such as interpersonal, family, and community dynamics, housing quality, social support, employment opportunities, and work and school conditions can also influence mental health risks and outcomes both positively and negatively. The distinction in behavioral health integration helps primary care practices better integrate behavioral health care into the practice. This distinction acknowledges PCMH-recognized practices that excel in this area. And these distinctions typically result in an enhanced level of care and improved access, clinical outcomes, and patient experience. So in order to receive the behavioral health integration distinction, the practice must report on 18 criteria across 4 competencies related to behavioral health integration. So the first competency is workforce. The practice incorporates behavioral health providers at the site, utilizes behavioral health providers outside the practice, and trains the care team to address patients' mental health and substance use concerns. The next competency is information sharing. So the practice shares patient information within and outside of the practice to support an integrated, coordinated patient treatment plan. The third is evidence-based care. So the practice uses evidence-based protocols to identify and address patients' behavioral health needs. And lastly, measuring and monitoring. The practice utilizes quality measures to monitor their patients with behavioral health needs. Overall, the PCMH approach leads to increased access to care, reduced ED visits, decreased costs, a reduction in team workload, and more satisfied patients and staff. In an article from 2013 in the American Medical Association Journal, it concludes that addressing social determinants of health within the PCMH model represents a high-value benefit to the healthcare system and has the potential to reduce the long-standing socioeconomic disparities in health that continue to persist. Okay, so I just wanted to mention some Medicaid quality measures that can be reported on, but I also want to point out that this is state-specific, so it might differ from the state that you're in. The ones that we've listed are from here in Massachusetts, where we are. All right, so the measures we have here: breast cancer screening, cervical cancer screening, diabetes, HbA1c, poor control, so that's over 9%, initiation and engagement of alcohol and other drug dependence treatment, and immunizations for adolescents. So a lot of these measures you'll see are very similar and in fact overlap with a lot of the QPP and PCMH measures. And then here we have a few more. So adherence, antipsychotic medications for individuals with schizophrenia, chlamydia screening and follow-up, HIV viral load suppression, TAPS for MIPS clinician group survey, and antidepressant medication. All right, so one of our colleagues is a bit of a coding whiz and did help us narrow down some ICD-10 codes related to social determinants of health. So we hope that our colleague Susan is here on this webinar, and if anyone has any questions specifically related to coding for social determinants of health, we'll have some time at the end of the presentation for questions you can ask her. So as a review, ICD-10 codes are international statistical classification of diseases and related health problems, and the 10 indicates the 10th revision of the code, so sort of like the DSM-5, the 5th version. We've also included here the link to the coding guidelines on this slide for anyone who's interested in reading a little bit more about them. All right, so we've listed out some ICD-10 codes related to education and literacy, employment, occupational exposure to risk factors, housing and economic circumstances, social environment, upbringing, family circumstances, and psychosocial circumstances. So these codes are a good way to identify patients for population health needs, for food insecurity, lack of housing, trauma-informed care, or any other social needs. We've also put here ICD-10 codes in regard to patient noncompliance. So this could be noncompliance with medical treatment and regimens due to dietary regimens, intentional underdosing of medication due to financial hardship, intentional underdosing of medication for other reasons, and unintentional underdosing of medications either due to age-related ability or for another reason. Now, there are a lot of other codes related to social determinants of health, and we've actually listed them in an appendix at the end of this slide deck, so it will be available to you after the webinar for anyone who's interested. All right, so we will open it up for some questions and discussion. I did just want to show you all, first of all, this is the contact information for myself and Radhika. I'll leave this slide up during the question and discussion period, so if anyone would like our phone number or email, you can have it. These are some resources we have. So our New England QIN-QIO macro website, which is naqpp.org. We've also included a link to our Ask a Question. We have also included the links to the CMS TPP website, the Mixed Participation Status Lookup Tool, the CMS portal, and the CMS TPP Resource Library. On this slide are all the sources from the data that Radhika shared earlier on in the slide deck about the work that's being done in social determinants of health. So if anyone's interested in reading more about that, these are the resources. And then here are the rest of the ICD-10 codes. Like I said, we've listed them all here. There's quite a bit. So we'll let folks peruse them at their leisure if they would like. So we can open it up to any questions now. To ask a question over the phone, I believe it's pound 6 or star 6? Pound 6. So press pound 6 to ask a question over the phone. Otherwise, type it in chat and we'll be happy to answer.
Thank you so much, Kelsey and Radhika. So for now, like Kelsey had mentioned, you can press pound 6 to unmute your phone, or you can type any questions in the chat box on the right-hand side of your screen. Just for a few last announcements before we continue with any questions, A reminder that we are now on social media, so please visit our Facebook, LinkedIn, Twitter, and YouTube page. When you do close out of the webinar, the evaluation will automatically pop up on your computer. If you could please fill that out, we would greatly appreciate it. If you don't have time to fill out the evaluation right now, or if you're currently sharing your computer with someone else, you'll receive an email tomorrow with a link to the evaluation, as well as a link to the event page on our website. And again, I'm going to put in the link in the chat box to everyone where you can find the PowerPoint presentation. Within the next few business days, recording and transcript of the webinar will also be added. And thank you again for attending, and have a great day. And I will open up the phone line for people to ask, or again, it can be asked through the chat box.
Thanks, Rachel.
Hi, Kelsey and Radhika. So we do have a question coming in from Michael. He's asking, besides claims, are there other tools to record social determinants of health that clinicians can use?
Thanks, Rachel. So, Michael, yeah, I'm not sure. I mean, I guess just in the claims or embedded in the EHR system of whatever practice they have. So, like one of the improvement activities was working with your QCDR to standardize processes for screening. So you can do that with your EHR system or registry or whatever system you sort of report your data through. I hope I'm answering the question.
We have another question here from Nancy, asking which SDoH screening assessment tools are most popular in the physician office setting?
Hi, Nancy. Thank you for your question. So one of the popular tools we know is Prepare, and there are actually quite a few. We can reach out to you after this webinar and send you a link to all of those surveys or, to assessment tools.
Okay, and then we do have another question from Karen. The PCMH guide shares links, or actually it looks like it's just a statement that Karen's making about the PCMH guide sharing links to specific tools you can use to fulfill each criteria.
Yeah, thank you, Rachel, and thank you, Karen, for noting that. There is a guide when you're obtaining recognition in the patient-centered medical home, and it does share examples of tools you can use for each criteria. So, yeah, that's exactly correct. Thank you.
And we have another question here from Jamie asking how much of this pertains to optometry.
Thank you for the question, Jamie. That's a great question. So the patient-centered medical home aspect of it is for primary care clinicians, but for anyone else, for the TPP and for other reporting programs for everyone else, and especially for optometrists, they are eligible clinician types for TPP. So it is absolutely applicable to optometry, especially to, making sure the comprehensive eye exams are taken care of. So I believe that it absolutely pertains to optometry, and I'm happy to connect with you offline if there's something in particular you'd like to talk more about in regards to one of these programs or all of them. Let me know.
Hi, everyone. Just as we're waiting for a few more questions, we do have the lines open for about another 5 minutes. Again, feel free to contact Kelsey and Radhika with their emails, which is currently on the screen, or again, you can press #6 to unmute yourself or type a question in the chat box on the lower right-hand side of your screen. Okay, everyone, we have about 1 minute remaining, so if you have any last-minute questions, please feel free to type them into the chat box or unmute yourself.
All right, we just wanted to thank everyone for joining. It was a pleasure sharing this information with you, and you have our contact info. So if you'd like to get in touch with us after today, feel free to do so. Thank you so much. Have a wonderful day.
Thank you.
The leader has disconnected. The conference will be terminated in 5 minutes.